Okay, great. Welcome, everybody. My name is Jane Hamer. I'm one of the Lunch and Learn teams. Welcome and thank you for joining us today. Just a quick little reminder about the Paediatric Society of New Zealand and the Neurodevelopmental Network, which is who we organise the Lunch and Learns from. So the Paediatric Society, it's an organisation for health professionals supporting children in tamariki and rangatahi across New Zealand. Joining the Paediatric Society is great because you get to engage with other professionals who are also passionate about supporting children in whānau, and there are lots of different special interest groups and discussion boards and conferences, and they support the New Zealand Child and Youth Clinical Network with lots of resources and up-to-date evidence, and it offers opportunity for education grants, of which I have been a recipient of, to attend part funding to attend a conference. So joining the Paediatric Society is a win-win for you professionally and also for the work that we do supporting children and their whānau. So today we are very lucky to have with us Chloe Davidson, who is a hospital play specialist. So she's a registered hospital play specialist and a teacher who's been working in Aotearoa for the past 14 years supporting pipi, tamariki and rangatahi, first as an early childhood teacher and then later as a hospital play specialist. And Chloe is currently also completing her Masters in Education and is the current president of the Hospital Play Specialist Association Aotearoa, New Zealand. And today, Chloe is going to be presenting to us about the role of hospital play specialists working with tamariki and whānau in hospital. And she'll highlight how they work as part of the multidisciplinary team to support children and whānau to create positive experiences when they're in hospital. So we're really lucky to have you joining us today, Chloe.
Thank you so much.
I'll just mute myself so that you can then share your slides and take it away.
Perfect. Thank you so much. Hopefully you can all see my screen. Yep.
Perfect.
Thank you. Kia ora everybody, my name is Chloe. I am going to take you through as quickly as I can some of what work looks like as a hospital play specialist. I currently work at Starship as a hospital play specialist and have worked on numerous wards throughout my time. So the stories I'm sharing are specific to the work I've done over my time at Starship. I'm just removing your faces because I don't know if you can see that on my screen or not. So the value of play is huge for our children, and as you can see here, play looks different for everyone, but we like to make sure that in a hospital setting, which is somewhere which is uncomfortable, unfamiliar, and can be quite traumatic for children and families, there's a way for them to have play and have fun. So the value of play, it creates an environment where children can connect to home. It means that children can express their thoughts and concerns and anxiety, and it can help them make sense of what's happening in hospital. And so you might walk past a playroom if you've worked with a play specialist or seen a play specialist before and seen what looks like just having a lot of fun and playing, which it definitely is. But there's a lot of things happening in the background, and that's how we develop our assessments of children and work out what their holistic wellbeing and needs are to support them in their whānau during their time in hospital. So it connects home and the hospital. Children obviously play at home, that's their safe space, and we want to make the hospital somewhere safe and enjoyable for them as well. It creates a sense of normalcy. We all go to work every day as our job. For children, play is their job. It helps lessens anxiety, it helps them cope, and it enables our assessment. Different types of play that we provide in hospital. So although it all looks like play, there are different types that we're providing and different types that we're looking at. So medical play is one of the types of play that we provide. And most of our playrooms, if you've seen, will have medical equipment set up. It might be a mini hospital or an ambulance like you're seeing in this picture, or it might be a little doctor's bag with dolls and things set up for them to role play and be a nurse or a doctor. And it just helps them to make sense of what's happening to them in hospital, to act out what's happening, to kind of build an understanding, and for us to see if there's any misconceptions of their understanding and gaps that we need to fill with our learning. Therapeutic play is another type of play that we support and provide, and this for us has no end goal. Therapeutic play is a way for us to provide children open-ended, child-led opportunities, and it may look like medical play, it may look like trains or painting, but it's a way for them to be a child and them to explore at their own pace. And we're coming along for their ride. It may not include a play specialist. It may be us setting up a space and environment for the child and their whānau or their parent to have some quality one-on-one time so that they can leave the hospital having some positive memories for them to talk about for the time they need to come back next. And another type of work and play that we do is preparation. So this young child was going to theatre and he needed to understand what was happening. So to prep him, he chose to use his leopard from home, and he took his leopard through his surgery process, and he took photos, he asked questions, we talked about the different steps, and he took these photos for him to remind himself as the day went on and while he was waiting, because as we all know, the acute list can be quite hard for children to wait on. So for having something tangible to replay and revisit is a great way for them to feel that sense of control over the uncertain hospital environment. So we like to talk about myths about children in pain, and a big one for us is lots of infants. We often hear they'll be fine, we'll just do their immunisations quickly, or they won't remember it, we'll just do their bloods, they don't need any support, we can just get it done. And sometimes that's from parents and sometimes that's from professionals. But we know that by 29 weeks of gestation, the pathways and perceptions are well developed. And I always like to share this photo of one of the young girls I was working with. I worked with her from the time she was 6 weeks old, and she was in this papoose brace. As you can see, the little dolly is in her first original papoose brace as a 6-week-old. And now at 2.5, her mum brought her original one back in, and we put the doll in it in the playroom, and she was busy playing and role playing in the kitchen. And she saw the doll in the papoose brace, and she crawled over to the doll and she said to us, help baby, as she tried to pull the baby out of the papoose brace. So for us, she didn't have the words at 6 weeks old to explain how she was feeling and how hard it was for her. But at 2.5, she really did now, and she wanted everyone to know that it wasn't okay and she wanted that baby out. And once we took baby out, she was able to play and engage again and went back to role playing in the kitchen. And I think that's just one way to remind ourselves of things that we are doing and being done to our infants can be hugely traumatic and have long-lasting effects. So it's really important to consider what we're doing and how we're doing it, and is it the best way or best practice? And sharing that with families, because they don't always know too. They want to be educated by us. And I often hear it from nurses and from other professionals saying, oh, as soon as I walk in the room, the baby starts crying. And that's because often their uniform is quite triggering. It's a reason why a lot of play specialists don't wear uniform and why we're in, I guess, mufti clothing, because it doesn't trigger that stress response. And I often hear parents say, oh, like every time I touch their feet or someone touches their feet, they start crying. And that's because a lot of our infants have bloods done from their feet. They have blood pressures, like a lot of traumatic experiences are happening with their legs and feet when they're first born. And so part of our role is often educating and supporting parents to provide some positive touch to outweigh those negative experiences happening, which means we're going to have a better outcome later on. Something else we provide is distraction through procedures. Hopefully some of you have worked with a play specialist before and seen what distraction looks like, but it does look different. We make coping plans and distraction and alternate focus plans with children and families, working on what they enjoy and what brings them enjoyment and works well for them at home. So we're bringing the home into the hospital setting, and then we create that for them here. And you can see a little bit of medical play here on this teddy. I had a young girl who needed to go into halo traction. So to help her understand what was going to happen, we put her teddy into halo traction for her as well. Distraction works really well when it's done effectively. And when we're doing it before a procedure and making that plan. But often if a child's already had a traumatic experience and then we're trying to offer distraction or procedural support, it doesn't work as effectively. So it's really positive for us to be involved from the start and offer that support. I wanted to highlight, obviously, being the lunch and learn, some neurodiversity and how I have worked with children with complexity and neurodiversity diagnoses. And I guess I just had a couple examples here about how we work with parents, like the parents and caregivers know their tamariki really well and they know what works for them at home. They don't often know how to translate that into a hospital setting, but that's why we talk to them and we spend that time to create that coping plan for them. So one example I had was I worked with a young girl who was selective mutism and non-verbal. So whenever anyone apart from her mum was in the room, she wouldn't talk or communicate. And when it was just her and her mum, she felt comfortable to talk and express what was happening for her. She needed an MRI prep done. We were trying to assess as a medical team whether she could cope with a non-GA MRI versus a GA MRI. And adding in her autism diagnosis meant we needed to assess everything and what life looked like at home. So I went into the room, I prepared Mum. I spoke to her through the process knowing that her teenage daughter was in the room and was able to hear what I was saying, even though she never looked up or never engaged. And when you were in the room, she often did just freeze and not move at all until you left. And that her mum said that was her normal, that if someone unfamiliar was in her space, she would literally freeze. If she was mid-bite from eating lunch, she wouldn't be able to close her mouth or finish that bite. And that was just how she felt. So I talked to her mum through the process. I talked to her about what it would be like to have an MRI while she was a wasp. And then I left the room for them to talk to each other. And then came back 10 minutes later, agreed, and her mum was, sorry, I have a dog barking in the background. And her mum was able to say she thinks she can try it. She thinks it'll be okay. She'll keep really still, but she's really worried about doing this. She feels like we're asking too much of her. And I said to her, Mum, what do you want us to do? Like, how do you want to proceed? And she said, I think we should try. And then we started talking about the noise a bit more and what her daughter was like with noises at home. And she said, oh, actually, she's really bad with noises at home. I can't even boil the jug with her in the same room. She has to be at the other end of the house. And I said to her, it sounds like if she can't handle the noise of a jug boiling, going through an MRI, which is really, really loud, is going to be quite tricky for her. So we made her plan that way. So even though her mum thought she might be able to cope, at the end of the day, our recommendation alongside her mum and her were actually, if we could have an MRI under GA, would be the best outcome for her. And it did go well. That was definitely what was needed. Another, I guess, example is through ED. I've worked with children who were non-verbal ASD diagnosis, and it was a new diagnosis of diabetes and needed to have an insulin injection. This young boy, we spent a lot of time. I spoke to the nurse specialists and the doctors in ED, and we got a play or a prep pen, so it didn't have the needle in for him to practice. And we spent about half an hour practicing with the needle and practicing with the insulin injection to try and get him to be able to tolerate that and potentially even do it for himself or let his parents do it for him, because they were obviously his safe person. And he was so great. He played with it, he engaged. It took time to get him into even touching it, but he did. And then he was giving insulin injections to mum and dad and to himself quite confidently. But as soon as and his parents were really confident, they felt like it would go really well and we could swap it out and put the real one in his hands and we would be able to get his insulin dose in. And as soon as we swapped it out, he wouldn't practice anymore. He wouldn't play with it. He put it down, like he knew instantly. And they looked identical. The difference was the weight. We tried doing it without him seeing us swap them. But as soon as he touched it, he put it down and he knew. And we weren't able to get him to a stage where he was able to do it or let his parents do it, unfortunately. But his parents were really appreciative of the positive effect that it had, giving him the time to explore. that first dose didn't go well in the end, and he did need to be restrained for his first dose. But I actually saw his mum 2 years later, and she came back and said actually he got to such a good stage at home that he was able to do them for himself, and it became no big deal. He just would offer up a site on his body and do it, and if he didn't want to do it, he was happy for mum to do it, because we had showed them how to play and how to prep and how to build his confidence with that. So although the first instance didn't go well, the wraparound care, I guess, we provided the whole whānau meant that they felt equipped to continue that at home and get to a positive place for him. So it was so good to get that positive feedback that they were able to continue. It also means for our long-term patients, as a play specialist, we have the time. We're able to go in each day. We're able to offer consistency. A lot of our nursing and medical teams don't have that, whereas they're on shift work, they do 12 hours. You may or may not see someone again for another few days or a week even. So being there sort of Monday to Friday, offering regular consistency for children can be really positive, and can get to a place where we have our long-termers who won't do a procedure without us there, but as soon as we're there, they know the drill, they get into position, they'll happily have their alternate focus or distraction and let the dressing change or port access be done. Whereas we hear nursing teams and medical teams say to us, like, we tried for 2 or 3 hours last night, we had no success. And parents share the same journey, that it's really positive for them to see their child involved and participating rather than having to hold them down and do things a more difficult way. So I've got some takeaway tips for everybody. Obviously, play specialists aren't there 24/7. Things are always happening when we aren't around, because that's the nature of the hospital. So these are some tips that we often share. So getting down to the child's physical level. No child likes anyone standing above them. The importance of honesty. So if they ask a question, being able to give them the answer to that question, being able to tell them why we're doing something. Like, a lot of children aren't ever told why they're having bloods done or why we're doing this physio session. They need to know the why, obviously in plain language that makes sense and they can understand, because it can lead to a lot more. Include the child in the conversation, so don't talk over them, give them the time to ask questions, give them the time to hear what you're saying, respect their feelings, so match their mood. If they're really low and they're feeling it's really overwhelming, don't walk in super bubbly, because children have shared with us that that's not helpful for them. They want someone to get where they're at. We always say offer children choices and 2 acceptable options. More than 2 is too hard for them. But 2 options is a great way to give them autonomy over what's happening as well. An example of that is, obviously they can't decide if they're having an IV line put in or if they're going to theatre, but they can choose. I guess for an IV line, we would say, like, would you like to sit on mum's knee, or would you like to sit on the bed by yourself? Or would you like to ride on the bed with mum down to theatre, or would you like mum to walk next to you? So there's always a way to give 2 choices. The same for taking meds. Would you like your meds in a spoon, or would you like them in a syringe? So there's always one way to give 2 options, but you're still getting to the same end result. But more than 2 options is too hard. We would also say don't let not making a decision delay the moving forward of that process, because sometimes delay tactics are a way to avoid something, and it's a way that children might use to cope. So I would often say, like, keep pushing them forward. Like, if they're struggling to make a decision, and if that's their normal base at home, like, I would say to a child, I can see it's really hard to make a decision this time. I'm going to make this decision for you, and I'm going to choose. We're going to try the medicine on a spoon, and you can tell me afterwards if that worked for you and you liked it, or if next time you want to try the syringe, and then we'll know which one you like better. So we're kind of still pushing them forward in our plan of care and what needs to happen, but we're still letting them be involved in those choices. Include the parent and the child in the procedure. Parents often don't know where to stand or where to sit or what their role can be, and they often want to move out of the way of medical professionals. So as play specialists, we work really hard to include the parent and give them a role in the procedure. It might be like, can you stand here and hold this book? You guys are going to play I Spy. Who can find 10 butterflies the fastest? Or The child would really like you to rub their head and help them to stay focused. So you just need to be in front of their eyes and engaged in them at their eye level, and we will kind of try and stay out of their eye level. But a job for the parent is always really beneficial. It allows children to build some confidence. Oh, sorry. And a big one for us is the foundation for the future procedures. We know that every person at some point in life will need medical support or intervention again for something. Like, it's unrealistic to say this is a one and done, you're never coming back. So just acknowledging that whatever we're doing now will have lasting effects for the child for their next procedure, on whether they will come in, whether they won't, whether they'll allow a procedure to happen, or whether they're quite traumatized from what's happened before. So we don't want to ever do anything that's going to have a negative impact on the next time if we can avoid it, which is often what we're advocating for. How can we do this the nicest way possible to ensure that the next time round that child's going to go, I was listened to, I trust the person, they only did what they said they were going to do. I know I can go back for help. I didn't like it, but it was okay. Or that went really well and I had lots of fun, which sometimes does happen. Children are so well engaged during a procedure that they don't realise it's happening. So language matters, and the words and terminologies we use are really important. I'm not going to read through all of these because I know we are getting lighter on time. And I believe you will get the slides, so feel free to have a look. If you've got any questions on terminology and words, let us know. But we will often say, like, we're going to put in an IV lure or an IV line, and it's a really small tube or a really small straw. Like, we won't talk about it's a needle or something like that, just as an example. This is just another example of some medical jargon we use, which often to children means something different. So we talk about stool samples. For children, they might picture like a stool that they sit on at home or at kindy. We talk about bugs. Children might think of a little bug that they've seen or something crawling in the garden. We talk about drawing blood, and so they might think drawing with the colour red. We talk about a CAT scan. Children often think about a cat. So just some examples of sometimes when we say things that mean something totally different to the child. So we just need to be conscious of what terminology they use. And as a play specialist, I often ask first, like, what do you know is happening today? Because then mum or dad or the child can explain it in their words, and I can use that same words. Because for some families, flushing the line is totally appropriate to use, and in others it means something totally different. Or talking about going to theatre and saying we're going to have a sleep would be totally appropriate in some families, and some families that would trigger something in them because maybe Aunt Sally's just died, and so they're talking about, well, she went off to sleep. So we need to be careful of the language we're using, but it's not always going to be appropriate for every family. So a safeguard for that for me is definitely asking what they know is going to happen and then using their same terminology. And then I've just got, how can we create whānau-centred care plans? And I guess that's a chance for you guys to ask questions if you've got any. And then I will finish up with a karakia. Is there anything anyone wanted to talk through? I feel like it was really quick, but I know it's a quick session.
Oh, that's amazing, Chloe. If anybody has a direct question to ask Chloe, please feel free to unmute yourself now or put a question in the chat. Unless anybody's got a question now, I'll just wait a minute before. Oh, Sally, off you go, Sally.
Sorry, it's a rule, but it's sitting with Sally. Sorry, Jane. Hi, Chloe. I just had a query really about quite a few lovely young children in the community who have been through the hospital system, but they're now in the community and they're going through pre-puberty type hormonal injections at age 5 and 6, and it's really traumatic for them. And I was just thinking, is there any community services that might be available to work with them in terms of just what they're experiencing and support those parents really to get, to get through what is happening, and the fact that it's monthly.
Yeah.
And it's just becoming quite overwhelming for, and they're still under the system with paediatricians and everyone else, but it's just that they are not acutely in the hospital system.
Yeah, and that's what's really hard, and I wish and hope that will change soon. At this point in time, play specialists only exist in the hospital setting. We don't have any working in the community. It's definitely proposals we've put in and would love to see one in the community, because we often get children referred into hospital either as an outpatient, because at Starship we do have outpatient play specialist services. And I know some other hospitals around the country do as well. So we often get children referred back into us for that exact creating a care plan.
Okay.
I would love there to be something. There isn't, which is super tricky, but feel free to always touch base. Like, we're always happy to offer suggestions.
Okay.
And
Cool.
have a conversation. And I'm still always advocating for it. We put in a proposal last year. I will keep putting in proposals every year, because we see it. We see the need to support those children and families, just to create it. And it's, I guess for us, it's easy work to do. And once we lay those foundations, the family will have the skills to keep going, because it is a lifelong journey.
Yeah.
And we know that
Chloe,
every
it's
traumatic. Sorry,
I was just saying, I know Abby had set up a private play specialist like online service and things. I don't know if that's still running or whether that's something that would be accessible to your family at all, but
Yeah. Okay.
yeah, I can try and find the link for that if you're
Yeah,
interested.
that'd be great.
Yeah.
Because I think this lovely family, they've reached out to say we need some help. We're desperate. So so I was just listening to what you're saying. But Donna, that'd be great. Thank you.
Chloe, do you
Yeah,
still
that'd
know
be
about
awesome.
that?
I was trying to think. Oh, is it Abby Lynn?
Donna, do you know who you were referring to? Oh, Donna must be looking
Yes,
online.
that was who it is. Sorry, yeah, I was trying to look it up online. Yeah.
Yeah, so I believe, she does work in the community. I don't know exactly where she's located from the top of my head either, and definitely feel free to contact her, but definitely happy for you to contact either the Hospital Play Specialist Association or me directly, and we can try and put you in contact with someone close to where you are, or we can offer support as well. Like, there is a need, and we want to support those children and families, because at the end of the day, they are why we're doing what we're doing.
Okay. Thank you, Chloe. We'll reach out.
Perfect. Thank you.
Does anybody else have any other questions for Chloe while we have her here?
Chloe, my question was just following on what Arul was saying in terms of, like you mentioned, like support and things. So, in terms of the people on the call, if there's somewhere that they're wanting to get some support and they don't necessarily have a play specialist where they are, are there any resources or places you'd recommend to look?
We do definitely have stuff on our Hospital Play Specialist Association website, and we're looking at revamping that at the moment, so there's not a lot of new stuff on there, but there's definitely a contact. If you want to contact, you can email the association. That comes through to me directly, and I can support that or find someone in your area. Otherwise, I'm happy for you to contact me through my Starship email as well, and be able to work out how we can support or who is close, because it needs to happen, and I guess the more people who want that to happen could potentially help with our funding application, because that's the only way it's ever going to change.
Chloe, on your slides is there a website for the Hospital Play Specialists?
I don't think I did, actually.
So no urgency, but just maybe it could get included in the link that Cutty shares and puts onto the Lunch and Learn YouTube site, and then that way other people who are looking can be directed to watch the Lunch and Learn video again. Is that something that you can retrofit into it, Cutty?
Yeah, I can put it on the intro on the YouTube side, and I can also have a chat with our comms people to advertise it. Yeah. Great. So it's just going to comment. It's like I have a lived experience from having a daughter who had multiple medical procedures, and it got to the point that she needed a pre-med to manage the energy, and with some of your colleagues' work, the following time she went to theatre, she handed her to have the Ivy Lure put in. So the transition was just unbelievable. And that was not due to the medical teams, they're all lovely, but it was due to your colleagues that made a safe theatre time and distress and medication and all that, and reinstilled her trust in medical system. So thank you.
Oh, thank you. It's so great to hear, Kati.
Yeah.
Right. Well, we've come to the end of our very whistle-stop tour of play specialists, hospital play specialists, because of our little short lunch and learn series. And Chloe, I'd just like to thank you so much on behalf of the Paediatric Society for presenting here today. And just before everyone leaves, Chloe is just going to close with the karakia.
Perfect. Thank you. I'll reshare my screen. Can everybody see that now?
Yes.
Perfect. Mai e te tohurangi ki te tohinoku, te aho I roto, marama I roto, tupu mauri ora, ke te whaia ao, ke te ao marama, whānau, haramai te toki, haumie, huie, taiki. Thank you so much, everybody.
Thank you, everyone, for joining us today.